Greetings from Jabalpur. In this educational video, we demonstrate the technique of a transforaminal lumbar nerve root block. This procedure serves both diagnostic and therapeutic purposes, allowing precise delivery of medication to the affected lumbar nerve root. It is commonly used in cases of lumbar disc herniation, foraminal stenosis, etc. The target area for drug delivery is the Kambin's triangle, a safe anatomical corridor bounded by the superior end plate of the inferior vertebra, the superior articular facet, and the exiting nerve root. Briefly, the procedural steps are as follows. The patient is positioned prone and the midline and disc spaces are identified in the AP view. The entry point is determined by measuring the distance from the skin to the anterior longitudinal ligament on the sagittal plane. A Chiba's needle, 22 gauge or 18 gauge, is then introduced along the planned trajectory under fluoroscopic guidance. Correct placement is confirmed with contrast injection, ensuring appropriate perineural spread. Finally, a mixture of bupivacaine and steroid is administered at the target site. Our patient was a 60-year-old man presenting with low back pain radiating to the left lower limb, predominantly in the L5 distribution for the past 3 years. On examination, motor power was intact, the straight leg raising test was positive, and the Faber test was negative. MRI of the lumbar spine revealed a degenerated L4-5 disc with the lumbar canal stenosis and compression of the left L5 nerve root. The procedure was performed under local anesthesia with the patient awake and positioned prone. The orientation of the fluoroscope is shown here. The midline is marked and the L4-5 disc level is identified under AP fluoroscopic guidance. The distance from the skin to the anterior longitudinal ligament is measured in the sagittal plane. This corresponding length is then marked on the Chiba needle to guide depth of insertion. An equal lateral distance from the midline is also measured and marked on the skin to determine the entry point. At the entry site, 2% lignocaine is infiltrated for local anesthesia. A Chiba's needle is then introduced at approximately 30 degrees angle and advanced towards the superior articular process. The needle position is confirmed on AP fluoroscopy. Once bony contact is obtained, the needle trajectory is adjusted. Here the needle tip is seen entering the neural foramen. Iohexol contrast is then injected, confirming appropriate spread and demonstrating that the needle tip lies within the disc. The needle was then withdrawn slightly to move out of the disc and repositioned within the foramen, as confirmed by iohexol contrast. On the lateral view, the needle tip was seen at the foraminal entry, just anterior to the posterior vertebral line. The residual contrast within the disc was also visible. A 1.5 ml mixture containing equal parts of bupivacaine and triamcinolone was injected after careful aspiration. The patient experienced immediate pain relief with no neurological deficits. The do's of the procedure include confirm needle trajectory in both AP and lateral views, use non-particulate steroids like dexamethasone at upper lumbar levels. Always aspirate before injection to avoid intravascular or intrathecal entry. Observe for any neural irritation during insertion of the needle. The don'ts of the procedure include do not inject without contrast confirmation and do not force the needle once it contacts bone of the superior articular process. Instead, readjust the angle. Thank you for your attention.